Uh, we started pediatric anesthesia. We started with the normal physiological, pharmacological, anatomical changes in a way, making it in a way of the challenges to anesthetists, like challenges during the preoperative period, intraoperative period, postoperative period. What are the differences in the different in the conduct of anesthesia? What are the special points related to history, how to do the preoperative evaluation, and how to deal with the challenges related to IV lines, related to anxiety, how to cope up different monitoring or equipment required for the pediatric age group, how to deal in each and every step, including the enzolysis, aspiration prophylaxis, evaluation, monitoring, induction, fluid management, analgesia, then the specific surgeries which is being seen in pediatric age group. Okay, and then in the last session we just discussed. We started with the few of the congenital anomalies. We did infantile hypertrophic pyloric stenosis and congenital diaphragmatic hernia. So I think today we will try to just cover some of the other congenital anomalies. Okay. I will start with the. Just tell me one thing. What is the significance of presence of one congenital anomaly to anesthetist? Yes, Dr. Atik.
Can you repeat the question, sir? What was the question, sir? Sorry.
Usually, why, whenever we just hear that there is the baby has a congenital anomaly, okay? So what are related to the congenital anomalies which can haunt an anesthetist? Like what you will
Sir,
be thinking when I say, when one of your colleagues say that the next patient, next baby coming has some congenital anomaly. So what are the things which you may face in a patient in which you hear that there is a congenital anomaly? What are the challenges?
sir, if there is a one congenital anomaly, there may be associated other congenital anomaly as well. So we should be
Okay.
aware of that, like cardiac anomalies, we have.
Just a second, just hold on here. What sort of anomaly in cardiac will be haunting you? Every anomaly?
Sir, it can be VSD, it can be ASD, it
No,
can
no,
be
no. Try to
prof.
understand my question. That what sort of anomaly you will be worried? Like if the
Sir, we are
baby has residual PDA and there is left to right shunt, is it something to be worried?
sorry, we should be worried because there is PDAs.
The anomalies with cyanosis.
Just give me a second, please. Just a second.
Sir, you
What sort of congenital anomaly worried about?
sir, congenital anomaly, we are worried about the esophageal fistula, or sir, congenital diaphragmatic hernia, and sir, the acidosis, pulmonary hypertension. Sir, another thing is that, sir, prematurity is the most common thing, sir. Risk of aspiration and, sir, dehydration.
Okay, so I
And
will
sir,
repeat. I will just try to explain what I am trying to highlight. The thing, like for example, if we have a defect in the heart, for example, but it is causing left to right shunt. Initial stage, till the time it is causing pulmonary hypertension, and there is a chance of right to left shunt, reversal of the shunt, and causing cyanotic. This is not that much serious problem as compared to a problem with the other one. This is one thing. Number one. Number two, if for example there is a congenital anomaly which is related to airway, this is a problem for anesthetist. Okay. If there is a congenital anomaly in which there are chances of patient developing fits, okay, that is a problem. There will be some, like for example, there is congenital hydrocephalus. Now, this congenital hydrocephalus can cause neurological problems. Okay. So if you are having, if you come to know that, then you have to rule out any serious problems which can create trouble to you, while because the anesthetic medications will be affecting this thing. Okay. Like for example, if you have a patient with right to left shunt and now you have to give anesthesia, will anesthesia worsen this right to left shunt by causing imbalance in the pulmonary vascular resistance and systemic vascular resistance by decreasing the SVR? Am I right, Dr. Atik?
So yes, sir. Because from right to left shunt, there it will cause maybe it will cause cyanosis.
Yes, that's
And
what
when
I'm saying, that it will cause worsening of the symptoms. Okay. So that is the business end. Like if you have a patient with the with a syndromic child, like for example, Down syndrome is a congenital anomaly. This is a genetic defect in which there are multisystemic involvement in the form of airway, in the form of chances of patient having hypothyroidism, patient having atlantoaxial subluxation, the difficult airway. So this is the business end. I'm just talking about that whenever you are facing any baby like that, you have to look into the things which are causing problem to you, like airway. There are so many congenital anomalies in which there is distorted airway. Okay, so that is more serious problem for anesthetist. Okay, just so after this initial few words, now we will go towards tracheoesophageal fistula. So what are the congenital anomalies associated with tracheoesophageal fistula? By the way, what is tracheoesophageal fistula?
Sir, tracheoesophageal fistula is a fistula which is situated between the esophagus and trachea, the abnormal tract. And so, there are 5 types of tracheoesophageal fistula, in which most common is type C, in which there is a blind upper esophageal pouch with 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 fistula between the lower segment and trachea is also there. There's communication between the
You are talking about this thing. You see, I tell you something. If you forget the A, B, C, D, E, F, G, for example, that is not that much important. You have to remember that there is a blind, there is esophageal atresia, and there is distal tracheoesophageal fistula. Okay. That is the thing which
fistula between the esophagus, the fistula between the lower end of the
yes.
trachea and esophagus.
Yes, like there can be any anomalies like this. There can be separate. Okay, there can be upper and connecting to the trachea and with the blind pouch. Okay, so this is the one which is more common. There can be connection like this. Okay, so there is upper and lower both, or if there is connection between the trachea and esophagus. Okay, so there can be any type, but if someone asks you, you can explain rather than A, B, C, D, E, F, G. You should be telling that the more common is the one with upper esophageal blind pouch and distal tracheoesophageal fistula. Okay, so this is one thing. So like yesterday we talked that there is some selling point or highlighted point. So just repeat what is that symptom with which they can, if they are asking you in a oral exam, what word they will be using?
Sir, there the word is like choking
On feeding, choking on feeding, and inability to pass the
inability to pass the catheter down to the stomach. Except one human condition, there we can pass. In all 4 we can't pass.
Okay, so now the other question which you should be knowing, that what is the anomaly, that is this is the anomalous, that vectral or vetter. Okay, if there is cardiac anomaly, that then it become vectral, otherwise it is vetter. Just I will interrupt again for a second, just a second please.
Vectral means, sir,
Yes. You see vectoral, V for vertebral anomalies. Okay.
A
A for
for
imperforate anus.
and A for anal atresia, sir. C for is cardiac congenital cardiac diseases, and sir T is for tracheoesophageal. T is tracheoesophageal fistula, and R is for renal genesis, and L is for limb atrophy. I think so, if I'm not wrong.
Yes. Assalamu alaikum. Just G.
Cardiac defects are more. Cardiac defects are more 35%.
Yes. Okay. Okay. Sorry. So this is the you will be, and now next question is that how will you rule out? Like what investigation would you like to do if you are having this suspected tracheoesophageal fistula?
Cardiac defects can be ruled out by 2D echo and ECG and X-ray.
Remember one thing: whenever you are answering this question, you will be asked starting from the history. Okay, so there will be some history pointing towards some cyanosis while crying. Okay, and then you will confirm it by echo. This is one thing. Tracheoesophageal fistula, there will be something related to choking, coughing, vomiting, inability to take the feed. Okay. Imperforate anus may not be obvious immediately in the early days. Okay. But it will be diagnosed. Vertebral anomaly will be done on the clinical examination or by some radiological studies. Okay. And similarly, renal agenesis by ultrasound. Lib abnormalities will be also. So because this was the question asked, that if you have a patient with tracheoesophageal fistula, what evaluation would you like to do? Like what tests would you like to do? So one will be CBC for, would you like to do CBC?
Sir, we will do CBC and serum electrolytes, EBGs, X-ray chest.
Serum electrolytes for?
Serum electrolytes for electrolyte imbalance.
Because patient may be dehydrated, because patient is unable to take any feed. So this is the reason. Why would you like to do CBC? There may be some infection. Okay.
Infection, because, and sir, there may be some dehydration we can see, and sir, there may be, sir, HB can be, we can rule out the other coagulation.
Okay. Maybe. In X-ray, what can you find?
And actually, we can see from the abdomen, here in the abdomen, entering the fistula, and we can see, we can rule out that answer.
You will find some infection. So you can find pneumonia. You can find lung collapse. Anything. You see, you are entering the abdomen. Which is more important for you? Abdomen or thorax?
Thorax.
So why are you starting with abdomen? Try to be that, because you see, you are anesthetist. You should be focusing on the things which are related to anesthesia first, then go to the something else. Okay. So you can find some infection. What about echo? You can find the cardiac anomalies. Okay.
Cardiac anomalies. Cardiac
and
ECG,
again, is it a medical emergency or a surgical emergency?
It is a medical emergency, sir.
You will be discussing with the surgeon. You will be have a multidisciplinary team discussion. Okay. And then you will be doing it. You would like to have an ICU bed. You would like to rule out any cardiac because you know what's the reason for it? Because in our centers, it's not available. But actually, if the congenital anomaly of heart is creating more trouble, so there are very non-invasive ways to correct them. Like, for example, if the patient has VSD or ASD, there is a device closure which can they do. It's their decision to do what time of the life or what would they like to do. Okay. For example, if there is a patient in which there is a duct dependent circulation, you will have to give prostaglandins to keep the duct patent. Okay, because in that scenario, maybe the baby will not survive if duct is closed. You understand? So you will be discussing these things with the cardiologist and the surgeon. So you will make a, and the main aim is that it's not an emergency to do it immediately. You will be evaluating the patient and then you will decide what to do. Okay. So we will recap that we find a congenital anomaly, we look into the other systems. Importantly, whatever systems are important to us, we try to be focusing on that system, and then we just this is the usual way that there can be some other congenital anomalies, and then we do try to chalk out which type of fistula is it. Okay, so you see they will be these days usually these things are diagnosed antenatal period. Okay, so it may be diagnosed antenatal. So in that case, you will be doing accordingly managing the patient to start with in the same way that it should be. But otherwise, you see, like they have written here, fluid and electrolyte correctness, sepsis. Okay, so you will be looking on the things objectively in the exam when they are asking you. Try to answer in an objective way, and it's very easy. There is no science. That science is common to any topic. Electrolyte imbalance will be there in any patient where the patient is losing the fluid or volume from the any orifice or from anywhere. Okay, so this is a common thing. If there is any obstruction and there is increased gastric volume, there will be chances of aspiration. It can be in adult or pediatric population. So you have to, and that you will never forget. Whenever there is any infection which is involving the lungs, there can be chances of pneumonia. Okay, so you will be looking at that way, because especially in the babies, the pulmonary, this one compliance is already decreased. So there are more chances of developing pneumothorax or things like that. So you will be having the lung protective strategies. Okay, so this is a common way to approach any patient, and that will make your life easy. You don't have to memorize that, oh, what is written in the page number XYZ of Morgan or problem oriented, and you have to recall the words and you have to throw the same words. You have to be away from that thing. Just you are answering the question conceptually. Okay. Okay. So usually to avoid specifically in this tracheoesophageal fistula, you will be putting NG in the blind pouch and do the suctioning. And what sort of induction would you like to do in this patient? Would you like to do rapid sequence induction, or would you like to ventilate the patient? What should be your aim?
Sir, first of all, we will prepare the patient and correcting the electrolytes and prop up the patient to minimize the reflexes, and putting the NG. Then we will give the anticholinergic drugs to avoid the bradycardia and to avoid the secretions.
If the exam they will asking you, would you like to induce with rapid sequence induction, or would you like to ventilate the patient, or would you like to do inhalation induction?
There are two school of thoughts, but I would like to go with safest with AVIX inhalation induction. Sir, I will go with inhalation with avoiding PV to avoid gastric distension.
So you use the word safest. So there is nothing safest. Okay. Try to avoid these fancy, beautiful, attractive words, because there is nothing safe in anesthesia. Safe is only lap of the mother and sitting on the bed. There is nothing else is safe. When the patient is inside the OR, you cannot use the word safest. Okay. There is, you have to, you have, if you are doing one technique, there is problem with the other. If you are, for example, if you are trying to give rapid sequence induction, your patient become apneic and you are not able to ventilate, or sorry, you are not able to intubate, you will be ventilating the patient. There will be air in the stomach. Patient will not be able to ventilate, and patient, because there is communication between the airway and the GIT, you will lose the patient. You will say like that. If you are doing, you are using the word awake.
I would like to.
Awake is one option. Awake is one option. You can do awake intubation. This is one option. Number one. Number two, you can, the better you will not use the word best. Just a second.
Awake fiber optic, sir, number one. Second is the inhalation induction without
you are not
relaxant.
again not using the word which I am trying to highlight. Just listen to me. I'm saying that what is the difference between inhalational induction in a way that you are preserving the spontaneous ventilation, so that you are not begging, because when you are giving positive pressure breaths, the air is going and inflating the stomach, and that is creating the problem, because this will also compress the lungs, and FRC will even decrease further, and there will be more chances of patient getting desaturated. Okay, so the word which you are using now, you will highlight that the main aim is to preserve the spontaneous ventilation. Okay, so whenever you are the same is approach in the congenital diaphragmatic hernia. It is better not to do the positive pressure breaths, because it will cause pneumothorax or cause raised airway pressures in case of congenital diaphragmatic hernia, and here it will cause aerophagia, which will worsen your situation. Okay, so it is better to have inhalation reduction with preservation of spontaneous ventilation. That should be your answer. That is the better and safer, not the safest or best. Okay, try to avoid these words, because if you use these words in the exam, now the examiner will caught you, and you will not be able to change your statement. If you have used the word better, or this is one of the choice, and you can have this one like that. If you are doing this thing, this will be the problem. If you are choosing the other way, that is the problem. Okay, so that should be your answer. In that way, you will not be able to caught by the examiner. Okay, so you understand? Jiatik bhai, do you understand?
I understand, sir.
Okay, so you will be discussing what will they require. You will because it will be dependent on the surgeon, what technique they are using, what approach they are using. But maybe they are asking for one lung ventilation, may be required to have one lung ventilation. Okay, maybe you will be having problem in the intubation. So what is the question they ask in the exam? How to intubate a patient with tracheoesophageal fistula. The first step we discussed, that will be inhalation induction, and how to confirm the position of the tube.
Sir, we can confirm the position of the tube by fixing the tube distal to the fistula, and then taking out again the tube and fix it. Then we can hear the breathing pattern on both lungs. We can,
if you just start the word that the same word which you use, that our aim is according to the type of the fistula, but usually we should be fixing the tube between carina and distal to between carina and the fistula, like distal to the this one fistula, and proximal to the carina. Am I right?
yes, sir, you are 100% distal to the fistula and proximal
to the carina. So there may be different techniques to do it. Some people will do it endobronchial and then gradually withdraw when they have a bilateral, and then they will withdraw further, and then they will be observing the gush sound in the stomach. Okay, and that will be the place where is the fistula. Then they will push further down again, and then again that the gush sound will be lost, and there will be bilateral air entry. That will be the place to fix the tube. The fixation of tube should be in a proper way, because that is of utmost significance. If you don't fix the tube properly, you may dislodge the tube. Okay, so they can do it in lateral decubitus position. They can do it. There will be different techniques used by the different surgeons. Okay, but whatever they will be asking you, the main focus will be either about that technique, how you start the anesthesia, And as we discussed before, what in addition to the standard 1, standard 2 monitoring, which monitoring would you like to do in this patient, Atik bhai?
Sir,
Or
we
which?
will have, in addition to the standard 1, standard 2 monitoring, we will have invasive blood pressure monitoring, and along with it, we have the temperature monitoring and the urine output monitoring.
Temperature monitoring is associated in the standard 2 monitoring. You can say it. Temperature monitoring is very important in babies, and then they can ask you about where to monitor the core temperature and the surface temperature and rectal temperature. What is the difference in it?
So in the we can monitor the core temperature in the tympanic membrane and nasal, and we also use the rectal temperature for
Nasal, no, not nasal, not nasal. Middle 1/3 of esophageal temperature is relative to is a like a better one, or what is the most accurate one? Most accurate one is through the pulmonary artery catheter. Okay, this is the most accurate one. Tympanic membrane is one option. Middle 1/3 of esophagus is another option. Okay, and the rectal temperature will be 1 degree centigrade higher. Okay, so you can choose and interpret accordingly to the place you are monitoring the temperature. Okay, and
can
as
we use
discussed,
urinary catheter temperature?
urinary will not be very accurate. It will also be giving, but I'm not sure. Okay, but esophageal middle 1/3 of esophagus, pulmonary artery catheter, and tympanic membrane. Okay, but because usually we are using in these patients, wherever it's available, it's esophageal. Okay, esophageal is we are using in the pediatric patient, but in this scenario, because they are doing the surgery over there, you can use even rectal, and then you can monitor the temperature accordingly. Or you can, if there is tympanic is available, because surface will not be a good choice, because you are using the bear hugger or patient is covered, so that will not be a very accurate one, because that may be telling you more temperature than the actual core temperature. Okay, in this scenario. So, and in addition to the we discussed yesterday this the concept of preductal. So you will be using right radial artery for the preductal solution. Okay, and then
along with every monitoring stand 1, stand 2, and already we mentioned we can use preductal to keep the, although it is an old method.
Yes, don't you have to tell it, but you have to tell the better things as well. Okay, the this one precordial stethoscope you have to tell, and then we did not, I didn't that we have, you can confirm the tube position with the fiber optic. That's what they have written here. Okay, so that's what we discuss of auscultation of breath sounds, right band stem, then gradual withdrawal until breath ventilation is established, ideally about 1 centimeter above the carina, chest radiograph, ultrasound. If a gastrostomy is present, bubbling versus lack of bubbling. Okay, so that's what I discussed. By the way, I have not read these articles, because these articles are published after I finished all my studies. This article is published in 2017 when I had closed all my books, and whatever I had done was done before. Okay. Anything else in this case? There will be post-op monitoring.
What about the gastrostomy? Should we do it before, or what is the role of gastrostomy, sir?
Is it your decision?
Sir, but if there is a
listen, Dr. Atik. Listen, Dr. Atik. You are. I will be pardoned to point it out, because I'm your well-wisher, and I have to stop you from peeping into the things which are not related to you. Even if the examiner is asking you, I guarantee you they will not fail you on the things which are not related to anesthetist. Okay, there is only 1% chance that someone will fail you about the decision of gastroscopy, but there will be failure if you are not able to explain the role of positive pressure ventilation versus spontaneous ventilation.
Sir,
or you are not?
it is a
Sir,
role.
if the
It has
fistula
a role
is,
of.
sir, if
Yes,
the
It has
yes,
a role
please.
fistula
of.
connects to the carina or mainstem bronchus, then there is role of gastrostomy tube for intermittent venting, because if the fistula is on the carina or mainstem bronchus, you cannot ideally place the intubation tracheal tube. So that's why you need a gastrostomy tube for intermittent venting
Yes,
and
these
And,
suctioning.
are the
and,
things. That's what I
second
tell
one is,
you. That is
that,
specific.
sir.
Sorry, Dr. Atik, I'm interrupting you. The thing is that these are the specific things like one leg ventilation, thoracoscopic surgery, or gastrostomy tube. These are specialized things. Okay. When they are asking you in that question, they have to assess whether you have good concept of pediatric anesthesia or not. Okay. So you will not be failed in this question on this point. I guarantee you. If they are asking you this question,
Sir,
it is
because of the gastrostomy, we can prevent gastric distension. And second is that, sir, it can prevent reflux of the gastric content in the lungs. Third is that, sir, it allows, if it is elective procedure, it allows proper nutrition of the baby in pre or post operative periods. And fourth one is it prevents elevation of diaphragm, avoiding respiratory distress, sir.
yeah, you are right. I'm not saying that you are telling the wrong thing. I'm just telling you that this point is not to be worried about. Okay. If you know it, if they ask, then you deep into this thing. If they're asking you the basic thing, try it, because 5 minutes will be finished if you just focus on the table viva, because this will never be a long case. If this question is being asked to you, this will be like last question to be asked. This will not be the first question. Okay. So because in every topic you will find such things, and I am trying to drag you away from these things. Just try to focus on the common things. Don't forget about the concept of this preductal if they are discussing you any congenital anomaly. Okay. If pediatric anesthesia, I should be telling the physiological, pharmacological, and anatomical considerations related to temperature, related to monitoring, relating to enzylysis, relating to post-operative apnea. These are the things which they are expecting from you in general anesthesia, because these things are specified pediatric anesthesia things, which they will not ask you in your anesthesia exam. Okay. From any other people, anyone want to comment or ask any question? Anything related to this tracheoesophageal fistula? Because
what are the post-operative complication of
post-operative complication will be related to the respiratory, like pulmonary system, or any surgical or anastomotic leak, or anything related to like other congenital anomalies, like patient can have this cardiac problem and that may be decompensated. Okay. There can be some post-operative problem in the weaning. There will maybe development of some pneumonias, infections. So these will be the things which will be focused. Okay.
Careful post-op suctioning.
Yes, that's another question. This is more appropriate a question. Would you like to extubate the patient immediately, or would you like to keep the patient intubated for a long time? Yes, because that's a more challenging thing.
Sir, we can extubate. We can
Sir,
extubate.
mostly patients they remain intubated and receive positive pressure ventilation in the immediate post-op period.
Yes, but whenever they are doing this, make sure the patient is knocked down, like patient is not fighting with the ventilator, because if there was a communication which was an osmosis was done, if the patient is either you extubate or either you keep the patient fully knocked down. Okay. Because if the patient will be in between, this can create more problems, and this will be disrupt the anastomosis. And actually you will be seeing, you will be discussing with the surgeon, there will be a multidisciplinary team discussion about the plan. If the patient is having the optimized conditions of extubation, you can do it. Okay. But this will not be solely your decision whether to extubate or not. Okay. So you can answer this question in a very nice way, that it will be discussed by the whole team. How was the surgery gone? What was the surgery done? How was the anastomosis? What are they expecting? So the advantages of keeping the patient ventilated will be outweighed compared with the extubation. So this is a very simple answer to pass the exam. Okay. So there can be things related to the prematurity in the same question. So what are, if we just jump to this prematurity, so what are the concerns in a patient, and any comment on this tracheoesophageal fistula? I think we have tried to cover the things which are important for the exam. They have written here caudally placed epidurals. These are hi-fi things. Okay, if you are not, if you can explain to them, otherwise don't tell. And the multimodal analgesia, as we discussed in our previous setting, that we can use paracetamol, NSAIDs, question mark, in some scenarios which you will not be using it. Opioids, if you are extubating, there are chances of post-operative respiratory depression, especially if you are using long-acting opioids. So there you have to balance between good analgesia and respiratory depression. Okay, so you can have in these days, it will be depending on the NCN and the technique they have used. Okay, paravertebral block can be used in some certain scenarios. These days, erector spiny block is being given. So erector spiny block can also be used. Okay.
Sir, what about the blood loss? Sir, we can't hear you.
Sir has muted.
Tell me about how can we say that how much blood is required? We should arrange blood because
we have discussed this scenario yesterday. Because of in the babies, you have to calculate the blood volume. You have to be very meticulous about the allowable blood loss. You have to calculate the transfusion triggers. There is no special which you have to discuss in this tracheoesophageal fistula. We have discussed the common things in our previous discussions. Okay, how to calculate the blood volume? How will you calculate, Atik bhai, blood volume in a baby? Like if you have a 3 kg baby, how much will be the blood volume?
If it is a normal baby,
yes,
then we have to be weight of the baby and into 90.
Okay, if it is premature, it can be even more than that. Okay, then you will be calculating the allowable blood loss. Am I right? But usually you have to be very meticulous about the calculation of the blood loss. And if you are expecting, you have to arrange the blood. Okay, and if it is bleeding, you are expecting more than 10 to 15% of the blood volume, you have to replace it with the blood, because there is very less margin. You have to be very meticulous in the calculation of the blood loss as well. Okay. Okay. So next part of our topic is this one, prematurity. So what are the concerns in a premature baby?
Sir, in premature baby, there is concern of the dehydration, concerns of the hypothermia, concerns of the postoperative apnea, concerns of the conceptual age, concerns of the lung prematurity, concerns of the high oxygen retinal
No,
prematurity.
not high requirement. You have to avoid high FiO2s because that will be creating more problems.
And sir, concerns of the all concerns of the prematurity, like congenital anomalies as well, sir.
Like all the physiological, pharmacological, and anatomical consideration in any baby, you will be there. But additional will be that you have to look into the cause of it. There will be chances of lung complications because of not development of the lung because of absence of this surfactant. Okay, so this is one of the thing. The other thing will be that there will be more. The baby may be below the weight. Baby can go in hypothermia more than other baby. Okay, and there will be chance.
Bronchopulmonary dysplasia.
Yes, bronchopulmonary dysplasia. And if you are giving high, patient may be requiring high FiO2, but at the same time, if you are giving high FiO2, there are also problems like you say bronchopulmonary dysplasia. There are chances of development of retinopathy of prematurity. Okay, so these are the things which
the challenges of IV cannula, apnea,
patent arteriostosis, ischemic gut, necrotizing enterocolitis.
Yes,
hypothermia, infection, intracranial hemorrhages.
Yes, what is that called, the terminology for intracranial hemorrhage? An intraventricular hemorrhage, to be very specific. Okay, like if we just summarize it, that's like the problems which you are facing in any baby, those problems will be exaggerated. Okay, like there will be more chances of patient going in hypothermia, hypoglycemia, pulmonary problems. There are chances of remnant fetal circulation. Okay, so these will be the things. Otherwise, we have almost discussed everything.
So there may be problem of anemia in these patients, in these babies, premature babies. Sir, you told us that there will be problem of apneic spell, bronchopulmonary dysplasia, membrane disease, and sir, hypothermia, hypoglycemia, hypoxemia, difficult inhalation, difficult difficult intubation, and fluid probabilities.
Whenever they will be asking you this question in exam, okay, that you will have to use even smaller equipment. That maybe very, very small, like maybe 1 kg, for example. So the things which you are using, you will have to be in more challenge. You have to calculate the medications, IV cannulation, like everything which you are doing in any baby, that will be exaggerated. Okay. So, and there are specific procedures which you can do in, like they have just chalked out here. There will maybe requirement of laparotomy for necrotizing enterocolitis, PDA ligation. Okay, there can be hernia, fundoplication. Okay, vascular access under X-ray. This is a very common thing. Okay, and they maybe have hydrocephalus, things like that. Actually, this question is least likely to be asked in your oral exam as a separate. They will be asking you with any other congenital anomaly. Okay, so this will be the background.
Sir, what would be the preferred technique? Is it regional or G?
Regional? What regional anesthesia would you like to give? For which procedure would you like to give? Sorry?
Blocks.
That will be combined to anesthesia. Which procedure would you like to do in pure regional? Would you like to give spinal?
So caudal can be.
Caudal, which surgery would you like to do in caudal? That will be for a part of analgesia. That will not be the core anesthetic technique. Okay.
Okay.
So why can't we give spinal to neonate or infant?
We can give. but whom among us have got the experience? So the things which we are not doing it, we are unable to explain in a very nice way in the exam. Okay, and nobody is
Sir, are you
expecting.
giving finals there?
No, I am a normal anesthetist. No, I'm not a pediatric anesthetist. Okay.
Sir,
I'm
you are working in a hi-fi setup, so that's why I'm asking.
No, you are absolutely right. But I'm trying to explain to you that as Dr. Atik said, we can give, and people give it, but it is not commonly used as we use it in adults. Okay. So in your exam, I think it is not a recommended thing until the examiner asks you, because next question they will ask you how much dose you will give. So you will be stuck in a problem. Try not to go towards that side unless they drag you. And this is least chance that they will ask you about a spinal anesthesia in a unit. Okay.
Sir, we should avoid opioids in a premature patient.
Yes, because like we discussed the concept of how to calculate the post-gestational age, how to monitor the post-operative apnea. They will be like up to 60 weeks post-gestational. We have to monitor for post-operative apnea. Actually, we discuss all these things in our first 2 sessions, the common things. Okay, so
Sir,
that will be related to
age of
temperature.
age of prematurity is less. If it is less than 38 weeks,
Okay.
it is a borderline.
Yes,
if it is
this is what you are talking. I'm sorry. Yeah, this is what you are talking. Okay, this is what you are talking. This is near like mild, moderate, and severe. Okay, and according to the body weights.
extreme is below 30.
I'm sorry.
Extreme is below 30 weeks of gestation, and
Yes.
moderate is 35 to 31. Okay, sir.
You will find in different books. You will find different things. Okay. So
how can we optimize the patient for prematurity? Can we give caffeine, IV caffeine?
Yes, in IV caffeine is used for. Why you are using IV caffeine?
Respiratory stimulant.
Usually in ICU they are using to avoid post-operative apnea.
Apnea, decrease risk of post-operative apnea.
Okay, and otherwise these are the same things which you know for any baby: fluid, intubation, monitoring, temperature, like whatever we have discussed before. The same things, concept of total body water and water-based medicines, like decreased metabolism, slow excretion, like these are the things which we have discussed before. Okay, so these are the common things. Anything which we have missed? We discussed about the use of cuff versus uncuffed endotracheal tubes. Okay, the advantages and disadvantages. And we discuss about multimodal analgesia in a baby. What are the blocks which you can give? Tab block, you can give other blocks I have discussed with you. Caudal block is very common. Armitage regime you should be knowing. What is Armitage regime?
It is the regime. It is the regime in which we can use standard type of dosage in the lumbar region. We can give 1 ml, and in the
sorry to interrupt you, because this is a bookish thing. I will be giving you the thing which you will miss, so I am telling you that thing. Whenever you are calculating it, you have to look at the weight of the baby, and you never have to cross the safe limit. Okay, because this 1 ml, for example, if you are a baby of 3 kg, how much is the safe dose of bupivacaine? It is 2 milligram per kg, for example. So safe gauge is 6 milligram. So how will you put it? For example, if you want to give it 1 ml per kg, okay, how will you give it? Usually in Armitage regime, it is written 0.25%. So whenever you are telling, you have to tell this word to start with, that if you are calculating this Armitage regime in a very small baby, you have to look into the toxic dose, safe dose, And if for example, the normal recommended you are trying to use that one, that will cross it. So if it is like that, you have to dilute it so that you are not crossing the safe limit. Okay. So for example, if the baby is 3 kg, yeah, I have 6 milligram is the safe dose. So 6 milligram, you have to calculate it. So if you are using 0.5%, sorry, if you are using 0.25%, how many mils you can use maximum? You will use only 2.5 mils. Okay. So 2.5 mils, how will you give it if you are using it for a higher block? Okay. So you have to tell, it's not difficult. It's a very simple thing, but you have to tell, because that is the thing which they want to ask you in that. In the books, everything is written. In the exam, they are trying to check how you are interpreting those books. Okay. So try to have the failure points first. If you are unable to tell this thing, they will fail you. I guarantee you. Okay. So what else? We have almost discussed all things. You see the fluid volume.
Can you tell, sir, if you're not discussed, can you tell me the different scales of the pain scales in the child or something?
Pain scales we have not discussed, and it's not the scope at the moment. Okay. Anything related to prematurity?
What type of tube we can use, or size of the tube?
Size of the tube, cuff tube you will use, or uncuffed tube we will use. We have discussed actually, but usually you will use the formula 4/4 plus age for normal babies. Here premature you are using 2.5. Okay. And this will be a variable. Always these formulas are to help you, but there are always exceptions. Okay. So these almost we have done all the major things related to prematurity. Okay. I'm just trying to have a look. Anything which we have, anyone wants to add something? Like you see there in the key points, they are seen during anesthesia and premature provision of a thermo-neutral ambient temperature is important. High airway pressures and pulmonary hypertension can lead to reversion of the fetal circulation with right to left thumb shunting. Apnea tolerance is greatly reduced in small infants, and use of classical rapid sequence induction has been questioned. Okay. As acetaminophen and regional anesthetic technique must be utilized fully to reduce opioid usage. Newer volatile agents with caudal analgesia can be used successfully for inguinal herniatomy in premature babies. These are hi-fi things they have written here. Just a second.
Please. What's about liver? Immature liver bleeding tendency, drug metabolism.
Yes, we have to give. That's why we give vitamin K, and there is a chances of bleeding. That's why we give vitamin K, and we can expect hepatic rupture, even hepatic bleeding. Sorry, coagulopathy in premature babies.
Low albumin affect my anesthetic management, anesthetic drugs.
Yes, usually these drugs are globulin bind. Usually our anesthesia drugs mainly are bind to globulin. Okay, so there will be changes in some of the drugs binding, but usually I cannot recall. If you can tell what are the drugs bound to albumin, because yes, you can say that there will be more. If there is low proteins, there will be more free drugs. Okay, but usually our drugs are bound to globulin. So the main effect is on albumin. Just someone correct me, because I have a slightly weak concept on it. Anyone can tell about it? Yes, Atik bhai. That's what she just pointed out.
Sir,
we discussed.
the premature, sir, because of the not developing of the hepatic enzymes and and they are not developed. So the drug dose will be very, very low and very, very less we would give.
No, actually, I'm trying to find the answer for the question which he has asked. It's a very good question, actually. What is the effect of low albumin in anesthesia? So which are the drugs which are bound to albumin? Maybe we will find the answer in this.
Acidic drugs, sir. All the
Acidic
drugs.
drugs. So if you can,
Acidic drugs,
because
they bind
usually
with the albumin.
albumin. So A
And
for
the basic,
albumin, A for acidic. Yes, 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 you are
and
right.
the basic drugs, they bind with the other proteins. I think
Globulin.
globulins. Yes.
Okay, so actually more effect on, that's what I had in my mind, that the majority of the anesthesia drugs which we deal are bound to globulin rather than albumin. Okay. Okay, so if we missed, because we will be discussing pediatric anesthesia for some time, we will be discussing a small topic now. What is Down syndrome? What are the anesthetic consideration in patient with Down syndrome?
Sir, it is a congenital anomaly usually present in the pediatric patients, sir. And the concentration of the Down syndrome are they have a problem with the airway, cervical instability, and sir, there will be cervical dislocation, sir, cervical instability.
One thing.
And
number two.
And so number two, in the patient there will be cardiac defects, cardiac cushion, endocardial cushion.
What else?
And sir, in these patient, the Down syndrome patients are the
try to be think logically. One thing you told about airway, you finished the airway. There is small trachea. There is small trachea. Okay.
Small trachea, and so we should use the 1 centimeter, one tube less.
Not 1 centimeter, 1 millimeter. One size less. 1 millimeter is big one. One size less. Okay. So you will be using a smaller endotracheal tube. Because of cervical instability, there will be chances of, like, you are not able to have the sniffing position for the intubation. If you do it, there may be that can be creating neurological injury. Okay. So this
also
is one
there
thing.
is subglottic stenosis is also there.
Subglottic stenosis, and then there are chances of hypothyroidism. There are chances. So effect of hypothyroidism. Whenever they are asking you this question, I'm expecting a better answer from you, Atik bhai. You will be saying that physiological, pharmacological, and anatomical consideration in any pediatric population will be considered. Okay. And some of them will be exaggerated, like this, because of cervical instability, there will be you will be having problem in the laryngoscopy. There will be chances of small trachea and subglottic stenosis. So you will be using a smaller endotracheal tube. You will have difficulty in short neck because of hypothyroidism. The effects of anesthesia may be prolonged. These patients have tendency of seizures, so they may be taking anti-epileptic medication. If there is some congenital anomaly, there may be right to left shunt and cyanotic heart disease. So there may be problems related to that.
Hypertension.
Pulmonary hypertension. Okay.
There may be
now I just hidden these things, and now I am showing it to you. And the rest of the things is aspiration. Try to tell the things which are important to us. And whenever you are chalking out the things, you have to tell the result. Like there is chances of gastroesophageal reflux, combining it with difficult airway. So that is a problem for you. Okay. And you will have all the problems that which we have discussed before. Problem of anzulisis. There will be problem of communication.
Respiratory infection, immunity problem.
Yes. Whenever there is aspiration, there will be chances of pneumonias. Okay. So these are the things which are related to what we have already discussed. Okay. So if you are able to tell these things, whatever, now you can go in detail. Cardiac, endocardial cushion defect, Phallus tetralogy. Okay. And whenever there is a congenital heart disease, the problem is to maintain a balance between pulmonary vascular resistance and systemic vascular resistance. If systemic vascular resistance is decreased and pulmonary vascular resistance is increased, there will be shunting from the right side of the heart to the left side. That is a problem for anesthetist. So in that scenario, you have to maintain the systemic vascular resistance. And that is a problem, that what are the anesthetic medications you are using are decreasing the SVR. So you will be trying to minimize this effect. For that, you are using, for example, ketamine, you are using phenylephrine, you are maintaining the fluid volume. So these are the things you are trying to maintain the stress so that pulmonary vascular resistance is not increased. So objectively, you should be looking at it. If you are using anti-epileptics, there will be some involvement of the liver. There will be some involvement in the electrolytes. There will be some bone marrow suppression. So these are the, yes. And then you have to maintain the therapeutic levels of the medication the patient is taking. You are trying to avoid the the epileptogenic medications. Okay. So these are the things which you are be looking at it. So if you know the buzzwords, you can expand, but try to tell the things which are related to anesthesia. Okay. So these are the things. For any endotracheal intubation in a neonate or you should have a leak. Okay. Because if you put it very tightly, there will be chances of postoperative edema and postoperative obstruction. Okay. So laryngospasm is also it, but actually laryngospasm is something else. Laryngospasm is one of the cause of upper airway obstruction. But if you are putting a tight tube, that is causing edema, that is causing postoperative problem. Okay. That will be causing edema
And
rather than pulmonary emergency.
Sir, there is post-op chest infection, and sir, there is post-extubation croup, and there is hypotonia.
Yes. Okay. So we discussed some of the things before. So some of the things are coming again and again. So you see, these are the things which are related to the hematology in the Down syndrome, like leukemias, and they will not go in that much detail when they are asking. Hypothyroidism is important for you. Okay. And because of atlantoaxial instability, you should be knowing what are the sequelae of the anterior subluxation, posterior subluxation, lateral subluxation. I cannot recall it, but you should be knowing it. Maybe they have written here, maybe. Okay. But this thing, even this MCQ, they ask this question. In the MCQ, they will be asking you what are the effect of anterior subluxation, posterior subluxation, something like that. Okay. So, okay. So I think we have discussed the main pearls, and that's how you have to read these articles. You don't need to cram, like, no, God forbid, any holy book. You just have to extract the important thing and throw it away. Okay. Because these days everyone is watching Artagal. So you see Mongolian, the word Mongolian came here. Okay. Just have a look on.
We are not having brain genius mind like you, sir. We repeat it again and again, then we memorize it.
Yes, because you try to memorize everything, and I don't try to memorize more than few things. That's why I don't forget. You are trying to cram the too much details. Okay. So that's why you are not able to pick the important things. This is one thing which was missed in the other. This impaired cellular immunity, and one thing which is not written in the other article was OSA. Okay. These patients have chances of obstructive sleep apnea. So you have to rule out obstructive sleep apnea. Obstructive sleep apnea can occur either in bariatric patient, like obese patient, or in this one, any patient with the adenoids, tonsils, or things like that. Okay.
Acromegaly.
Okay. Yes, this is another thing which they will be asking you, that what murmurs are important. So all murmurs associated with cardiac signs or symptoms will be important. All pansystolic and diastolic murmurs, late systolic murmurs, Loud murmurs, those associated with a thrill. Now someone will be asking which is left, but usually you will be, this is the most important
But
thing.
innocent murmurs are left.
Innocent murmurs are left, okay, which you will not be able to understand. But actually the message is that diastolic murmurs are more important. And if murmur is not associated with any cardiac sign and symptom, that will be not as important. If you have any murmur which is with cardiac sign and symptom, in babies there will be sign symptom related to the cyanosis. This is the most important thing. The baby will not be able to take the feed. That is that's a serious sign and symptom. Okay, so we will just do one more congenital anomaly before we finish. What is gastroschisis and this one, omphalocele? You see, gastroschisis is the only congenital anomaly which is usually isolated, which is not associated with any other congenital anomaly. Okay, and usually the problem is that there is a problem in the abdominal wall construction, like there is defect in the anterior abdominal wall. So if you compare it with the omphalocele, one defect is the central and one is the usually parambilical in the peripheral area. Okay, so which is more serious, gastroschisis or omphalocele?
Omphalocele.
Sorry,
Omphalocele, sir.
Omphalocele is always with a covering. No. Gastroschisis is more important, more serious. Need to be collected.
It is because of dehydration, but because of the rupturing, and sir, but it can be corrected and without any. It can be corrected, but regarding the omphalocele, it has got the anomaly association with the congenital anomalies. So it is more dangerous.
No. I'm telling you, I will repeat my question. If you compare omphalocele versus gastroschisis, because in gastroschisis there is no covering. Okay, so abdominal viscera can rupture. Okay, and there is more chances of dehydration as compared to omphalocele.
Hypothermia, infection, and dehydration.
Yes, so that is the defining point. Yes, you're right that with omphalocele there are other congenital anomalies. So that is making the life more complicated. So if you are comparing it, you see, never use the word best, worst. Try to be diplomatic like a politician. Okay. So these are the things related to it, and these are the things which are away from it. Okay, so the same thing which we have already discussed: fluid resuscitation, care of herniated bowel decompression with NG tube, which you were telling about. Nitrous should be avoided. Okay, nitrous, actually about the nitrous, there are two group of anesthetists in the whole world. Some of them like me, I love to use nitrous oxide whenever possible. Because there are critical steps before that you have to stop it. Otherwise, you can use in any surgery. Of course, in the exam, you don't need to perform the anesthesia, so you better say, I will avoid nitrous oxide. Okay, but actually, practically, things are a little bit different. Okay, use of nitrous and the rest of the things you will find all the same. Okay, I will try to read some or discuss with someone who is doing pediatric regional, and maybe I will be able to have few words about it. Okay, so that's what these are not very important things. The main important thing is, again, dehydration, presence of other congenital anomalies, and other problems which we are facing. Okay, so any question before we finish? Okay.
Sir,
yes, Atiq,
should we?
Yes,
Sir,
Tayyab.
should we advise echo for every Down syndrome patient?
Yeah, this is a question to Dr. Atiq. Yes, Dr. Atiq, what will you answer for this question? In what scenario would you like to have an echo?
Sir, I would like to do echo, sir, in the especially in Down syndrome patient.
Okay, actually, because usually it will depend. You will, if what sort of surgery you are going. Okay. But usually if there are some signs of that spells like feature or cyanosis on crying, that will be strong indication. Okay. Otherwise you can rule out, and then according to the level of surgery you are going for, you will do. Okay. As a general rule, if you are doing any elective case, it is better to rule out. So you will be doing it. Okay.
Okay.
Okay, everybody, thanks a lot for your presence. Special thanks to my, today I was quite apprehensive because for the first time, my head of department, my boss, one of my very senior, my boss, Dr. Fathi, he is also on board. Thanks, Dr. Fathi, for joining. And I was really worried to, because of your presence, I was quite apprehensive as well. And thanks, Dr. Yashar as well. Okay. So I hope it was fruitful for everyone. If I did some mistake, please do comment on, because I will be sharing on YouTube. So you can follow it. If anything by mistake I have told something wrong, I will be very happy to be corrected. Okay. So we will do some other topic in next discussion.
Sir,
Thanks a lot.
what would be, sir, excuse me, sir, what would be the next topics, so that we should be familiar with the topics and prepare at least
pediatric rest of the pediatric anesthesia. Maybe we will be doing the acute upper airway obstruction and the respiratory complications in pediatric units.
Okay, sir. Okay. Thank you, sir.
Okay. Everyone, bye bye. Thanks a lot for your presence. Jazakallah. Assalamu alaikum.